Every year, in the United States alone, about 39 million women go to a clinic or a hospital for a mammogram. It's one of medicine's most powerful tools in the fight against breast cancer. But the sheer scale of those screenings creates a massive logistical puzzle, and often it leads to an unsettling phone call.
If you think of the volume of mammograms, 40 million, 10% is a huge number. And what this means is a doctor after the mammogram calls you and tells you may have cancer, so we would like to follow up with you, which means you take another appointment, and that appointment may come in 2-3 weeks. And for this 2-3 weeks, it causes an unnecessary anxiety for the patient. So this is one of the challenges for us.
That's Eren Ahsen, a professor of business administration here at Gies College of Business. He's an engineer by training, but his work now focuses on a question keeping the medical industry up at night. There's a global shortage of healthcare professionals, and that includes the specialized radiologists who read all of those mammograms. At the same time, we're hearing a lot about artificial intelligence and its rapid advance. You've likely heard people talking about the potential for artificial intelligence to take jobs from humans. But for Professor Ahsen, that's the wrong question.
But the question we ask in the research is not can AI do the job, but what is the best way to integrate AI into clinical workflows in a way that's cost-effective and clinically safe. So we didn't ask the question, can we remove the radiologists or take the jobs of the radiologists and let AI do the job? But we asked that, can we use AI to help people to make their jobs more efficiently?
I'm John Moist. This is Research Reverb, and today on the show, an interesting idea, using machine learning to help doctors triage effectively by waving through clear cases and flagging the tricky ones for human experts. Ahsen and his co-authors recently published research examining the economics of mixing human experts with machine learning algorithms. They built a model to compare 3 different ways a hospital could sort its breast cancer screenings. Think of this a little bit like Let's Make a Deal. Behind door 1, we have the experts-only strategy, in which a radiologist examines every case. Behind door number 2, we have the automation strategy. That's the future you've heard so much about, where AI takes the wheel and delivers a decision about the case. But Ahsen's found the sweet spot, door number 3. Behind that door is the strategy he says makes the most economic and clinical sense right now, delegation.
Basically, this is a hybrid strategy. And what we do with this strategy is, so every mammogram is first read by the AI. And if you think how fast the computers are, in a second, read by AI, we get a decision whether we have a cancer suspicion or not. So AI screens all the cases for only high risk or ambiguous ones. So, and that is what the delegation strategy is. So again, AI screens all the cases, but only sends certain cases by the radiologist. So
in the delegation model, AI determines the straightforward, low-risk cases. If the computerized system notices a problem, it can notify a human doctor that an expert should take a look. To test whether their framework actually led to efficiency gains, the researchers used real-world data from a global AI crowdsourcing competition, the Digital Mammography Dream Challenge. They took 18 different algorithms developed by teams all over the world and tested them against the performance of real flesh-and-blood radiologists. By letting the algorithmic predictions select problematic cases, the researchers predicted that hospitals could reduce their screening costs by up to 30%. But efficiency matters less if it comes at the cost of accuracy. The researchers built the model to ensure that its detection rate, or its sensitivity, met the level of a human expert for a safety-first approach that reduces false positive rates. Let's step back for a moment and talk about liability, because this is where things get a little complicated. In the real world, this math isn't just about a doctor's time or the costs of running software. It's about what happens when things go wrong. If a doctor misses a diagnosis, for example, lawsuits might be involved. But what happens if an algorithm misses it?
Well, the liability in our model and in practice is not specific to models, yes? So there's a litigation. Let's say you say a patient does not have cancer, but after you give that decision in 6 months, the patient has developed cancer. So If you had given that decision 6 months before, the patient will spend that 6 months receiving treatment, and the prognosis will be more favorable. At the end of the day, by giving a false positive in this case, false negative in this case, missing cancer, whoever gives that decision, human or AI or human, may be liable for that. And there is a lot of litigations that has been reported in the literature. So that is one liability. Although rare, there is also liability in terms of false positives as well. Let's say your patient actually does not have cancer and you say that patient has cancer, the patient has gone unnecessary procedures, anxiety. There is, although rare, that there are cases that has been also litigated in the courts as well. So both false decisions, false positives and false negatives have litigation and liability implications.
And there are other trouble spots to watch out for. A model that performs well in one hospital might actually struggle in another.
We see this in research. One algorithm performs very well in a given population in a hospital system. It does not perform very well in a different hospital system. Why? Why is that the case? Well, there are several reasons. One, the population demographics is an important factor. But we are building these algorithms with data from a certain population. If the population that you apply is very different from that population, obviously you will not expect the same performance. Second, there are things like as unseen as like for example, in the case of mammography, one reason that we have performance difference is that different hospital systems use different machines to take the mammogram. Well, that's also an impact on the performance.
Because of the nuances and risks in play, Ahsen says that it's important to extensively validate these algorithms before putting them to work. But if the experts get this right, it could empower them to find similar changes that together can completely shift the patient experience. In many cases, 2 or 3 weeks might pass between getting that phone call after a mammogram visit and the next available appointment. Ahsen's also looking at how this same artificial intelligence framework could alleviate that anxious wait.
What we are doing is we are trying to use AI for same-day diagnostics. Right now, what happens is the mammograms are read first come, first serve. So if I came first in the day, the radiologist first reads my mammogram, then reads the second one, then reads the third one, and the patient is asked, to go home because you don't know what their wait time would be. What we are asking in that research, in a follow-up research, is the same idea. Let the AI read the first. If there is a high risk of cancer given by AI, and AI gives this decision in seconds, yes, I take my mammogram, in 3 seconds AI will say high risk, low risk. Then don't send a high risk exam to the end of the queue. If there is a suspicion of cancer, don't send the patient home. Do the diagnostic the same day. That means a win for the patient, so no anxiety for 2 weeks. Send it to the beginning of the queue.
AI is often sold and marketed to us as a way to outsource human judgment and decision-making. That's a long way off, and the jury is still out. But in the high-stakes and high-pressure world of medicine, artificial intelligence breakthroughs might look less like replacement and more like tools and enhancements to existing procedure.
Future of AI in healthcare isn't about replacing humans. It's about using machines wisely to extend human capacity. Our delegation framework isn't just a technical fix. It's a design principle for effective human-AI collaboration. So it lets us blend the precision, efficiency, judgment that serve both the patients and the healthcare organizations better. So what I say is when we do it right, it can improve outcomes, it can reduce cost, it can reduce patient anxiety.
At the top of the show, we talked about that wrong question dominating headlines. Will artificial intelligence systems replace human labor? When we stop asking those wrong questions, we can start asking better ones, like, how do machine learning tools fit into an actual clinical workflow? And how do they change patient experiences? We might not have the answers yet, but if frameworks like these can help bump a high-risk patient to the front of the line, or if they can turn a wait of weeks into days, that's a win we can celebrate for now. You can read more about research like this coming out of Gies Business at giesbusiness.illinois.edu. I'm John Moist. This is Research Reverb. Thanks for listening.